evening, and welcome to another wonderful learning experience brought to you by your Department of Continuing Medical Education. Before we get started, let us open with a word of prayer. Father God in heaven, we come before you this morning with a thankful heart. There's so much for us to be thankful for. You have blessed us tremendously. You have opened many doors for each of us individually. And that we ask that you just help us to always have a heart of thanksgiving. As we are about to begin another education session, open our minds to receive that which the speaker has to offer to us today. We pray that you would be with the speaker as he imparts knowledge to each and every one of us. This I pray in Jesus' name. Amen. So, this morning, we are super excited to bring to you a case from the Department of Family Medicine. So, without any further ado, I want you to welcome Dr. Keith Rivers, who will be presenting on behalf of the Department of Family Medicine. Dr. Rivers?
Thank you so much, Dr. Wallace, and thank you, everyone. Good morning, everyone. What a hearty welcome. It's quite an honor and a privilege to be able to present to you this morning. So before we start our presentation, um, I just want to declare that I have no conflicts of interest related to this presentation. I have not received any financial support, consultant fees, or any other benefits from any company or organization. Just as a test, is everybody able to hear me?
Yes, we can hear you well.
Excellent, excellent. So let's move on. So just imagine a patient who is elderly, bedridden, or simply too weak to endure the stress of travel, crowded waiting rooms, and the risks of infection that comes with a traditional clinic visit. For many older patients, this isn't just a hypothetical scenario. It's a daily reality and a major barrier to essential healthcare for many elderly patients. But what if we, as family physicians, could change that? What if we could bring quality medical care directly to older patients in the comfort and privacy of their own homes? Today, I want to talk about how we, as family physicians, are attempting to improve patient care through dedicated doctor home visit services, bridging that gap and putting the patient back at the center of care. In this presentation, I will show how home visits may change patients' healthcare resource utilization, including hospital admissions, medications use, and outpatient and emergency room visits. I will start by presenting an actual home visitation case, and this case will highlight the outcomes that occur due to family physicians' home intervention. Now, this is a case that I encountered when I was the resident physician in Abaco. Family members of two patients had called me and the nurse, the district nurse from Abaco, to visit two patients who were lost to follow-up. They both suffered from schizophrenia and they would not attend the clinic. And so we made an attempt to go to their home to deliver depot medication via injection so that, they could gain better insight and judgment and start coming back to the MHCAP clinic that we had every Monday. So when we went to the home, you could look at the home on the left. That's what the outside looked like. And it wasn't much more pleasant as we started to go inside. You can see the nurse and I attempting to go in the house through the front door, and that's the picture on the right. If you look on the left, you could just see me trying to get into the house. So this is me pushing to get into the house, but just look at the house. It's just filled with garbage. So these people were hoarders. On the right again, you can see the nurse. She's attempting to pull up the depot medication. But if you could look in the background, what was going on? These patients, they threw away nothing. they were hoarders. Everything that they bought, everything that they purchased, they left it in the house. If you look through the house again, this is the dining room, living room. You can see a figurine table. You can see an armoire. It's just filled with trash, filled with everything. You couldn't see the bed. On the right is the kitchen. You could barely make out the kitchen counter with some pots on the microwave, but everything was just strewn with garbage on the beds, on the floor, in the cupboards, on the countertops, on the table, everywhere. And this is what the bathroom looked like. And this is the bathroom that they used. It was still in use, as you can see by the toilet paper. And it was just a mess. And so, because of our intervention, actually going into the home to see a patient, we were able to directly help these patients. We called social services, we called environmental health. Social services found a place for them to live while environmental health went in and cleaned the house. So, as our population rapidly ages, with 20% of our population expected to be at least 65 years and older by 2035, healthcare delivery will have to change. Although the rate of new disability is slowly dropping, the aggregate number of ailing people who cannot easily go to the doctor will rise rapidly. Without house calls, the emergency room is expected to be the most common point of access, and hospitalizations will likely result more often. This sort of emergent care may temporarily solve a crisis, but will ultimately fail after a while. Without home care, these complex, bedridden patients will eventually enter a revolving door of repeat hospitalizations and emergency room visits, and even institutionalization, because the system fails to recognize the dire need to promote physician home care services. As a result, the emergency response strategy will become more expensive, both in dollars and in the quality of life of patients. This will leave both the patient and the physician frustrated by the fragmented care and cause them to wish for a better way. In addition to being better for patients and families, house calls often provide a unique opportunity to accurately assess the patient and give comprehensive care. I'll expound on this point a little bit more. When you think about the advantages of doing a home visit, these encounters provide the time for caregiver education, observation of how patients manage their medications, and also provides a glimpse of the daily socio-economic choices that the family face. Of course, we've seen this in the case that I've just presented. Clinicians practicing in the familiar setting of a hospital or clinic are expected to design treatment plans to meet the needs of patients who are homebound. But without knowing the home environment, these clinicians are at a disadvantage. And the reason why I'm using the word clinician is because sometimes it's not just the doctor that is going into the home. It could be the district or community nursing. It could be a PCA, whoever is a part of that healthcare management team. We all consider them clinicians. So the home setting encourages patients and caregiver participation in formulating and carrying out care plans. In the end, the caregivers are the most important participants in the healthcare team, and they are crucial to the ultimate success of patients' management and recovery. So before moving on, I want to highlight the major types of home visits that we offer as primary care clinicians practicing in an outpatient setting. There's illness, dying patients, post-hospital discharge, and assessment home visits. In terms of the dying patient home visit, just before COVID, I can recall a case when I worked at Fleming Street Clinic where a 95-year-old patient of ours died at home. A son who was in unfamiliar territory, obviously, called the nurse and I to assist. because we were the only persons delivering care to her for more than a year. So we went into the home along with the police officers, the morticians. We signed the death certificate and we offered grief counseling to the family members. And this is an important reason why home care should always be promoted by family physicians. So, what exactly happens during a home visit? Once we're in a home, we assess the patient's condition and manage them accordingly. We write their prescriptions. The nurse provides patient education as needed. We refer patients to specialty services such as nephrology, gastroenterology, or wherever else. And on occasions, we've even had to call the ambulance for very sick people who required emergency care. In addition to basic medical care, we also do post-operative assessment where we review patients who've recently had surgery. We change their dressing, we dress their wounds, and sometimes we even offer palliative care to patients with terminal illness, such as cancer or even end-stage kidney disease. In order to conduct a medical home visit properly, we must prepare properly. So I'm going to paint a scenario here. I'm sure that all of us as clinicians want to provide quality medical care. However, this can pose a dilemma in an area of productivity and efficiency. If, for example, your clinic has scheduled 10 to 15 patients per day, this might likely not leave enough time to do anything else. Now, let's say you learn that some of your older patients have become frail, bedridden, and are lost to follow-up, as in the case that I discussed just now. Trying to balance how to help these homebound patients while still delivering care to patients who attend the clinic doesn't have to be overwhelming. Schedule in 1 or 2 half-hour days per week for home visits can be one of the ways to concentrate exclusively on home visits. Now, there are some factors to consider when we plan our home visits, and these include patient location in respect to the clinic. So if your clinic is located, let's say, on Ponciana Drive, it might be easy to visit those patients who live in that area, like Big Pond, The Grove, Baintown. You want to consider the geographic concentration of the patients for efficiency. And what I mean is like, if you go into an apartment complex and you have 1 or 2 patients who come to your clinic, and they're all in that geographic area, you keep it so that you don't have to be traveling long distance because that's very tiring. You want to consider additional staff such as a nurse or patient care technician. When I do home visits, especially in the public setting, I always go with another person, whether it's a TCN, a registered nurse, a social worker, a PCA, but you need to take somebody else with you. And finally, you want to coordinate your home visit with the caregiver's schedule, especially for bedridden patients who cannot answer the door. And so you don't want to just show up at a person's place if there isn't going to be somebody there to let you in. I've had incidents where we've been. In fact, one memorial incident, the most memorable incident was when we went to visit a patient in Baintown, knocked on the door. Good morning, Ms. Smith. This is Dr. Rivel, the nurse. We came to check your blood pressure. Unfortunately, she said, well, I would let you in, but they locked the door, so I cannot get out. And so these are real occurrences. They're not just hypothetical. Now, I'm sure all of us, if not most of us, know about the black bag that the older doctors carried when they were going to visit a patient at home. So, in anticipation of the home visit, the clinician should pack some necessary equipment, and these include a blood pressure monitor, a thermometer, a pulse oximeter, and a point of care blood glucose monitor. And of course, a copy of the patient's files with the progress note templates. And I said a copy because you don't want to take the patient's original. You want to leave that in your office or in the clinic and transfer that information when you get back. With proper use of point-of-care technology, these services can be further enhanced. For example, portable devices such as HbA1c meters, cholesterol and hemoglobin testing meters can be used for personalized monitoring of patients at home. But patient-supplied devices such as scales, nebulizers, peak flow meters can add even more benefits to the visit. For more advanced practice, a portable EKG and a portable ultrasound machine may also be useful. So, how do we mirror what is done in the clinic with what we do in the home? It is estimated that 60 to 80% of the services offered in an outpatient clinic setting can be offered at home. So here are some of the services we provide when we enter a home. Like I said before, we can write prescription, we can assess and dress wounds, we even perform urethral catheterizations at the homes. We take blood for lab testings. We provide patient education and other necessary services. Our home healthcare team accepts referral from a variety of sources, both medical and non-medical. The referral must have the patient's name, their age, their date of birth, the location of the patient, their telephone number, any relevant landmark, like the color of the house, um, caregiver's name and contact number if there is one, or any other information that can help us find the patient easily. In addition to what can be done at the clinic, home healthcare clinicians offer the ability to evaluate fall risk in the home, assess the general environment for safety and hygienic practices. We check for polypharmacy because Miss Smith needs her Lasix and her furosemide. We went to see an elderly lady's house in Oakfield, and she had so many medications, prescriptions, over-the-counter vitamins, herbal supplements. It took forever for the nurse and I. We took quite a while just to sort out all of her medication and explain to the caregiver what the necessary medications were and what were the as-needed medications. We also evaluate proper storage of medications. If you look here in the windowsill, in this house that we went into, an elderly diabetic patient had her insulin stored on the windowsill while it got degraded in the sun. We also check that the older patient is up to date with their flu vaccine, their pneumococcal vaccines, and we've also placed Mantu on all the patients with chronic cough who are not on any medications like your Zestro or your Vasotec or Pretorax that could cause a dry cough. In North America, and I would say less so in European jurisdictions, there has been a fairly recent but very important aspect of home care services called transition care management. Transition care management is a service that coordinates and manages care for patients moving from an acute care setting, such as a hospital, to another community setting, such as a nursing home, or even a residential home. It aims to ensure a smooth transition from hospital to home, prevent hospital readmissions, and improve patient outcome by providing follow-up, medication management, and coordination for medical, social, and daily living needs. A key requirement of transition care management is an initial contact, and it has to be within 2 business days of discharge, and schedule a face-to-face visit by the home care doctor or the nurse within a specific time frame after that patient has been discharged. Currently, the clinics who manage patients in the hospital are usually not a part of their primary care team. And while inpatient providers may do an excellent job in the hospital, they often do not do such a great job when initiating post-hospital care because this is unfamiliar territory to them. This is that zone of transitional care into which many chronically ill primary care patients often fall. So the focus is on improving post-hospital outcomes for high-risk, high-cost patients. This model of care requires an interdisciplinary approach involving face-to-face communications rather than relying on phone calls. Research has also shown more effective and better patient outcome. So in general, once a patient is discharged from the hospital, physician involvement is very limited during the immediate post-hospital phase, and the overwhelming majority of patients have no direct physician contact in this critical post-acute period. This gap in care management led to the creation of transitional care management team. And publicly or private, a team like this it requires very limited resources as long as the person has a skill, so it can be implemented not just in North America and in Europe, like I've stated, but also here locally in the Bahamas. The skill set for a transitional care clinician is extensive. The team should know how to manage challenging patients with multiple comorbidities, patients who are taking many medications, and those who utilize complex devices. They should know hospital regimens and should be comfortable providing these regimens in the home. They need to have a strong interpersonal skill to work effectively with patients, their families, and home healthcare agencies. This is especially important for patients who are grappling with serious illness and end-of-life issues. The team must also be able to correspond with and obtain clinical support from both inpatient and outpatient physicians. Knowing ventilator and tracheostomy care is also important, especially if patients require such technologies. But having access to specialists by phone can substitute or be of great assistance when necessary as well. The transitional care team must also know how to find, utilize, and direct family members and caregivers to community resources. And, and just to backtrack on that, in the case we were able to community resources that were available in Abaco or for the schizophrenic orders was social service and environmental health, and they were able to provide more than just clinical care, but also social medicine care. In some jurisdictions in North America and in Europe again, ventilators, parenteral nutrition, and intravenous therapies like antibiotics and fluids can be prescribed for patients who need home hospital care. Although the home has historically been a less technologically advanced setting, high-tech care delivered in the patient's home is now safe and often preferred by patients and their family, if they can afford it. So now that we've seen all of the different models and components that make up a home care service, what exactly is the benefit, if any at all, of a home visit? So doctors like myself who make house calls found that they uncovered more clinical problems and did so more efficiently than they do in the office. There was a research done on low-income, functionally impaired patients who enrolled in what was called the GRACE study, which provided comprehensive geriatric assessment by nurse practitioners who reported back to the family physicians. The study showed that among intervention patients, the home visits far more often uncovered and addressed depression, incontinence, and gait problems in patients with falls when compared with patients who were only in the clinic. Seeing the benefits, let's explore some situations in which care at home may not be the best option. There are certain situations where home care may be questionable or not recommended at all. These include, but are not limited to, inadequate heating or cooling, rodent and bugs, lack of electricity, no running water, no phone access, insufficient food or medication, unsafe neighborhoods. These factors are usually not known to physicians in a clinic or in a hospital, but are quickly recognized by the home care team who can make recommendations to help resolve some of these issues. Unfortunately, some socioeconomic problems are challenging and are very difficult to uncover or to fix. Of course, no home-based healthcare service would be successful without a nurse. And I can tell you that from first experience. The nurse who worked with me from Fremont Street Clinic, that's Nurse Colebrook, is actually the workhorse of home care service and the person who maintains the success and sustainability of the service. She assists with assessment, monitoring and clinical decision making, care planning, and coordination. She accepts referrals and schedules the visits. She's involved in every aspect of the patient care, including health maintenance and management. When there are gaps in care, she identifies these deficits and ensures that they are addressed. The nurse is the major provider of patient education because the doctors usually don't have enough time to provide education. Communication is key. In my experience, patients have a closer, more intimate and trusting relationship with Nurse Cobra. So they communicate more with her than with me as a physician, believe it or not. And she usually voices the patient's concerns so that they can be addressed. This last point, capacity building, is done only by the nurse. She is the only one that reaches out to the various services such as social service, urban renewal, and other services to ensure holistic coverage that maintains or improves the patient's quality of life. The patients have her telephone number. They call her either for emergencies or to address any other matters of concern. There are certain situations in which homebound patients are encouraged to reach out to their community clinics and seek help. Patients require home care when they have complex medical, functional, and social issues that make it difficult for them to attend the clinic. However, a patient need not be bedridden to receive home care services, but they must have a physical or psychiatric condition that prevents them from leaving home without considerable tax and effort. For example, the patient cannot leave their place of residence except with the aid of a supportive device, such as crutches, canes, wheelchair, walker, um, the use of specialized transportation, or the assistance of another person, or if leaving home is medically contraindicated for whatever reasons. Um, I've had a patient, and unfortunately, the person has demised, but was a violent schizophrenic, and they were very, very disruptive when they went to clinic. But because they were familiar with the nurse and I, we had no problem going and giving depot injections at the home in Angliston, and that person was able to be controlled without having to leave the home and being a danger to himself and others. Care for a loved one can be burdensome, and I can tell you from experience, it's very, very burdensome on caregiver. When I trained in the UK, we attended something that was called dementia clinics, and I can clearly remember it's etched on my mind and will never leave my mind. A daughter of a patient who had Alzheimer's disease saying, Dr. Rivers, as much as I love my father, sometimes when I see him, I want to kill him. She had to leave her job, take care of him, but he would put feces over the wall, break furniture, break dishes, and it was very, very burdensome for her. So it can be very burdensome on these caregivers, given the physical and emotional strain, the economic impact, and the sacrifices needed to care for bedridden patients. Some caregivers even ignore their own health. For example, The physical efforts needed to turn or transfer a bedridden patient may cause injury and exhaustion. Anxiety and depression sometimes occur in many caregivers, and they are isolated from social support. Some families simply cannot cope. Something as simple as monitoring blood sugar is easy for some, but impossible for others. Caregivers who have done well for years might fail to handle a new problem like urinary incontinence. The home care clinician must therefore be able to notice signs of inadequate care, both subtle and obvious. The home care clinician should never be led astray by assumption based on socioeconomic status. And what I mean by that is some affluent families provide inadequate care if they are unable to, if the caregiver who is assigned to them is unable to fill in, or if they cancel at the last minute. Conversely, we've seen some incidents where some caregivers with meager resources provide excellent care in the most complex and difficult situations imaginable. They have a lot of resilience. It's out there. You just have to go out to see it. As home care clinicians, we try to avoid being judgmental or imposing our values on families. In a non-threatening manner, we try to make every attempt to observe interactions between patients and caregivers, investigate medical conditions that may appear concerning, and pay attention to patients' preferences. If we feel that the care is insufficient, we have to tell the patient and caregivers of our concern and offer options. There have been encounters when we had to call an ambulance for patients who need more advanced care than was being offered at home. Oh, homebound patients, I could tell you, they live in all types of settings and all types of neighborhoods. It's natural for a home care provider to worry when he or she enters an unclean, a cluttered, a chaotic environment, or an environment with social dangers like domestic violence and drug trafficking. On the other hand, a home care clinician may feel safe in affluent homes that might actually be less safe than they seem. A home care clinician must understand the environment and take steps to maintain their own safety. Fortunately, in general, home care is safe. Patients and their families are grateful for the visits, and clinicians are safe even in urban neighborhoods. However, when there are overt warning signs such as physical or verbal abuse to a patient or direct threats to the provider by agitated or intoxicated caregiver, the clinician should leave that premises. Contact law enforcement once they're out of harm's way. Clinicians have a duty to protect their patients, but we must protect ourselves first. Although a rare necessity, law enforcement can accompany a clinician into the home of a patient if necessary, and I'll show you that in the next slide. Even though home visits are safe, a clinician must still need intuition. Suspicion of heavy drug use or alcohol abuse is an example. Structural damages such as rotten floors or ceilings can also put clinicians at risk for injury. Likewise, aggressive animals can pose a risk, but this is often remedied by calling ahead so that the patient can put dangerous dogs away before we enter or visit the premises. This is a case that I experienced of a gentleman who, and it wasn't a dangerous case at all. The reason why we called law enforcement was because we couldn't get him out of a really dilapidated house. You can see here on the left a uniformed police officer, and then this is a plainclothes superintendent that they came and they helped us get the patient out of the house. We put the patient in the ambulance, and but this is just showing you how we can use law enforcement when necessary. Again, I want to stress that we there was no danger posed to the patient or to the clinician. It's just that we couldn't get him out of the house that was very dilapidated, and so we had to call police to assist us to get him out. So today, many family physicians find ourselves at a crossroad. Do we continue to deliver care to bedridden patients in their homes, or do we discontinue this noble service that was once the primary mode of care delivery? Physician house calls can now be considered a niche service. And when I say a niche service, I'm talking about a service that caters to specific, specialized groups of patients with unique needs rather than providing the service to the broader community. And of course, there are emergent factors that have contributed to this decline. For one, patients face significant, physicians face significant time constraints due to busy practices, heavy workloads, and other commitments, making it difficult to allocate time for house calls. Inadequate payment from insurance providers for house calls is another significant dis what would I want to say? Disincentive for doctors. From my experience doing house calls as a public physician working at Flamingo Garden Clinic, Elizabeth Estate Clinic, Fleming Street Clinic, there was no additional payment for home visit. There was no travel or gas allowance and no risk allowance. As well, we know now that NHI provides community-based healthcare primary care coverage for all residents and all citizens. While they have always provided payment for telehealth encounters, home care is not currently a reimbursable feature. Travel time and, to a much less extent, safety risk associated with visiting private homes and a lack of necessary diagnostic equipment and support staff are also major barriers. Additionally, increased specializations and the growth of clinics have also added to the decline in home care services. Finally, the development of district nursing or community nursing service, both public and private, have also contributed to the decline. Nurses play a very important role in delivering home care, mostly going into the communities independently, but providing feedbacks with family physicians who can remotely assist with patient management. So now to conclude this presentation, it is important to note that as our population ages and the number of immobile persons increase, the demand for home visits will continue to rise. Technological advances have leveled the playing field, blurring the boundaries between what is possible in medical offices, hospitals, and what is possible in the home. And if you would recall, we mentioned some of these technologies, such as portable EKG and ultrasound scan, as well as the establishment of home hospitals. Home visits can provide high-quality medical care to complex patients who may otherwise go without consistent medical attention. And for many patients and their families, home visits are often a preferred way to obtain medical care. Patients are more comfortable and at ease with their providers, who in turn can directly observe the many factors that potentially alter clinical outcomes. I can truly say, as a physician who make house calls, that I have experienced professional satisfaction from my career, and I thoroughly enjoy the opportunity to spend time with my bedridden patients. Thank you, everyone, for your most gracious attention. God bless you all.
Thank you. Thank you so much, Dr. Rivers, for providing such a wonderful presentation, a comprehensive presentation, one which truly highlight the importance of home visits, the very important role that family physicians have in fulfilling that mandate for ensuring proper care for those who are unable to come to the clinic or other health facilities. At this time, the floor is open for questions and or comments. We have a comment in the chat. Good morning. A very timely and comprehensive presentation. Please provide the name, clinic, and contact number that we may refer patients from the ED. That is from Dr. Wells.
Okay, yes. Fleming Street Clinic is one of those, but also, even though I'm a family physician, I'm also a gerontologist. And so I work out of the Ansound Clinic, Foxhill Clinic, and Gambia Clinic. And fortunately, we are able to receive referrals, all referrals. We do not turn any patient away. Um, it's very, very easy to get into the geriatric clinic by simply referring the patients to on-site clinic. We will see them, we will assess them, and if necessary, we would refer them back to their primary care provider if necessary. For some patients with complex, complicated needs, we just keep them. Today, there is a trend where people are more legally inclined. And so they want an assessment by a trained, qualified physician to provide proof of cognitive decline. And so a lot of patients, they come to any of those clinics, mostly on sound, for assessment for guardianship and power of attorney. So anybody with any geriatric patients that require further assistance, please feel free to send a referral to the Ansound Clinic, and I guarantee you we will see them.
Okay, thank you for that, Dr. Rivers. We have another comment in the chat from Dr. Patakin who says, excellent. Now, Dr.
Thank you, Dr.
Rivers,
Belligan.
you have highlighted some very important things for consideration when going into the farm and or going out into the community to provide home care. And you showed many pictures that demonstrate some of them. In today's society, where we unfortunately have had an increase in violence, particularly during the day, a lot of younger physicians in particular are very concerned about going out to do home visits. How would you, or what would you suggest or recommend in that situations for those who want to but have hesitations?
Well, thank you very much. That's a very, very appropriate question. And my first answer is don't be afraid. There is no need to be afraid. Um, Many of us are here. We've schooled in Jamaica, and you know from doing our community health services, and we go out with the health aid in areas like Augustown and Tivoli and Mountain View, these areas that have been notoriously known to be crime-ridden areas. Rule number one, always wear your uniform. Look like a doctor. When we went into those homes, and it's no different here in the Bahamas, people are very respectful of healthcare providers because they know we've come to improve health and to save lives. And so they would say, good morning, nurse, good morning, doctor, because you look that way. They're not going to try to attack you. In fact, they would protect you. And so dress appropriately, never go alone, especially for female physicians. Take someone with you. Take a PCT, patient care technician, another nurse, a male healthcare worker. Dress like a healthcare worker. The people are going to respect you, love you, appreciate you for coming into their communities. And I must say, I've never ever been or felt threatened going into any community, urban or not. whether I was here in the Bahamas or in Jamaica. The only time I felt afraid was when those pit bulls and dogs come barking at me to bite me. Other than that, home care is pretty safe.
Okay, thank you. Thank you for that. So, for those listening who have considered or contemplated, you heard it from someone who has been there, who has done that, and who has been professionally satisfied from the experience. So, we have additional comments, Dr. Rivers, from Dr. Bevins. Awesome presentation. Um, there is a question here from Dr. Hannah. Is there a specific home care service for oncology patients?
That's very interesting. By the way, thank you, Dr. Bevins. Hope everything is going well in Freeport. There isn't a specific uh home care service for oncology patients as I know of, but I've provided home care publicly and privately to patients with terminal cancer. Um, a lot of times it's sometimes just ensuring that they take their medications. I remember with Nurse Colebrook from Fleming Street Clinic, we would go and we would give the abdominal injections of the androgen suppressant, goserelin, for males who have prostate cancer. And so we would instead of having to go to the urology clinic just to get an injection, we scheduled those patients and we gave those injections ourselves. I've had patients who I've had to put up line because they were dehydrated. And just recently, just last month, I visited the home of a patient, this process is privately, who has unfortunately stage 4 pancreatic cancer. And he was getting this chemotherapy at home. And so he had a 24-hour nursing service. And I went and I assisted the nurse in finding a line and ensuring that he got the delivery of his medication at home because that was what he preferred. And so doctors who are comfortable with managing patients for whatever reason, I don't know if there's specifically a healthcare team that concentrates um, solely on oncology patients. But again, like I said, I mentioned that word earlier, a niche. I don't know if there's a niche for oncology, but generally we're able to handle most cases unless it's a dire emergency that that totally requires hospital care.
Thank you for that response, Dr. Rivers. We have additional comments for you from Dr. Darville, Phyllis Darville. Excellent presentation, Dr. Rivers. Dr. LaVille says, thank you, Dr. Rivers. You are missed at Fleming Street Clinic.
Thank you, Dr.
And
Ravel. Thank you, Dr. Leville. I miss you all guys too at Fleming Street Clinic.
she further indicates that Nurse Colbrook continues to move those mountains
She
for the
does.
patients. Dr. LaVille continues further grateful to our other Fleming Street Clinic family medicine home visiting doctors. That's inclusive of Dr. Smith, Sands, Curtis, Johnson, and she's sending a big thank you to all of them. Dr. Roll Smith says, thank you for your insight, Dr. Rivers. Wonderful presentation.
Thank you.
I just want to draw everyone's attention to the chat. Please ensure that you complete the feedback survey for this wonderful presentation. Please note that this is for EMC credits. You know, we are at the end of the year and it's time for us to get those credits in. So please ensure that you visit Sunshine Learner, Enrollment Key, Life Learner, and complete the feedback survey. Also note that your name should be reflective of the name that you are registered in at the Bahamas Medical Council. So if it is not reflective, kindly take a moment to correct your name. Dr. Conliffe also says, thank you, Dr. Rivers. Excellent, as always. Dr. Tina
Thank
Beckelman
you.
says, fantastic presentation, as always, Dr. Rivers. You seem to have a good reputation there.
I'm actually blushing hearing that.
And she also sends her love. They really miss you at the Fleming Street Clinic. Do we have any other questions or comments for Dr. Rivers? Okay, I see no additional questions or comments. So at this time, I would like to thank, oh, Dr. Pinder Butler. Great presentation, Dr. Rivers. Home visit is very important. Thanks to all clinicians who provide that service.
Thank you. Thank you
Huge
very much.
thank you. A
Thank you so
huge
much.
thank you indeed. A huge thank you indeed.
Thank you
So it
much.
is So it is at this time that I would like to thank all of you for taking this time to level up in your education and engage in this wonderful learning experience. I would like to especially thank our presenter this morning from the Department of Family Medicine, Dr. Keith Rivers. It was a wonderful presentation. I thoroughly enjoyed it. And I thank you for taking the time to impart your wisdom and knowledge to us all.
Thank you very much.
So we will see each of you again for our last session for the year, which will be on the second Wednesday of December. Enjoy the rest of your day and have a wonderful week.